Good evening, everyone. Thank you, organizers, for giving me the opportunity. Thank you, Randeep sir, for giving me the opportunity. Today we will discuss about the Checkmate 9ER trial, which is the trial which compares Nivolumab plus cabozantinib versus sunitinib for the first line advanced RCC. The data of 3-year follow-up. So the rationale for combination of Nivolumab with VEGF TKI is there are two issues. First is incidence of spontaneous tumor regression in RCC. It is highly immunogenic. The other is there is high level of T cell infiltration and responsiveness to interleukin-2 and interferon alpha. The rationale for using VEGFR is the targeting the VEGF pathway may attenuate RCC-induced immunosuppression, which leads to disruption of angiogenesis, has been linked to enhanced efficacy of immune-based cancer therapies. And increased PD-L1 expression has been associated with shorter survival in clear cell RCC who are treated with VEGF inhibitors like pazopanib or sunitinib. So the rationale is to combine the VEGF pathway inhibitors with Nivolumab, which could potentially permit synergistic enhancement of anti-tumor immune function. So as we know that cabozantinib targets many pathways like VEGFR, which subsequently the downstream pathway of RAS, RAF, MEK and ERK, apart from VEGF, MET, RET, and the subsequent downstream pathway. So like MET, the downstream pathways are PIK3, AKT and mTOR. So in this way, cabozantinib inhibits the cell survival, migration, invasion and proliferation, and hence acts as an this is an anti-cancer mechanism of cabozantinib. So, to background of phase 3 Checkmate 9 trial, it demonstrated superior efficacy with Nivolumab and cabozantinib versus sunitinib in the first line advanced RCC. So the data cutoff of 18.1 month and 32.9 month, at both the cutoffs there was significant benefit of PFS, overall survival and overall response rate at primary analysis and subsequent follow-up. So this is a 3-year data cutoff, and after a median follow-up of 44 months. So it also includes the subgroup analysis by IMDC risk category and among patients who are completing 2 years of Nivolumab treatment. So the study design of Checkmate 9ER, the patients who are previously untreated or advanced metastatic RCC, who are clear cell RCC and any IMDC group, they were randomized into 1:1 into cabozantinib along with Nivolumab. Nivolumab will be 240 mg IV 2 weekly, and cabozantinib will be 40 mg. And the other arm was sunitinib, which was given as 40 mg day 1 to day 28 and 2 weeks off. The stratification was also done by IMDC score, tumor PD-L1 expression and geographic region. The primary endpoint of this trial was PFS by blinded independent central review, and secondary endpoint was OS, overall and safety. In this trial, Nivolumab was given for 2 years, and after 2 years, if the patient was tolerating well and did not have progression, the cabozantinib was continued. So we can see that in the in any intention to treat population, Nivo plus Cabo, the median PFS was almost double. We can see that it was 16.6, and in the sunitinib it was 8.4 with this impressive hazard ratio of 0.58. It also translated into the overall survival, in which the OS was 49.5 months in the Nivo with cabozantinib, and versus 30.5 in the sunitinib arm. That means we had a 14 months of OS advantage and nearly 8 months of PFS advantage. In both the cases, the hazard ratio was very impressive. If we subdivide regarding the favorable, intermediate and poor risk category, the benefit was there, it was seen in all the 3 subgroups. Definitely, we can see that in the poor risk or intermediate risk, the benefit was superior, because sunitinib, if we compare IO with TKI alone, in the intermediate poor risk, the benefit is far better. So these are the Kaplan-Meier curves. Here we can see that in favorable risk, both the curves start separating as early as 5 months, and the separation was persistent throughout. And in the favorable risk, the Nivo plus Cabo was, the PFS was 21.4 versus 13.9. In the intermediate risk, it was 16.6 versus 8.7. and poor risk was 9.9 versus 4.4. Here we can see in the poor risk the TKI alone fare very inferior, and we can see the curves, the separation was wide enough at 18 months. The benefit of the quantum of benefit was significant, 37.8 versus 7.2. And if we combine both intermediate and poor, it also had in all the subgroups we can see that Nivo plus cabozantinib fared better as compared to sunitinib alone. So here it's like the intention to treat population, it was the double PFS was almost double, 16.6 versus 8.4, and hazard ratio was 0.59. So overall also we had a 14 months of OS advantage with a combination of Nivo with cabozantinib versus sunitinib. So this is the OS data. We can see that in the patients who have favorable risk, the curves are nearly overlapping, whereas in the intermediate risk, it is separating wide, and definitely in the poor risk, we can see that the Nivo plus cabozantinib is, it is favoring the treatment over sunitinib in the poor risk especially, although it is there persistent across all the three subgroups. So moving on to the response rate, the overall response rate of the combination arm was 55%, and the sunitinib was 28.4. The CR and PR, both the CR, PR and both the things, they favor the combination arm of Nivo and Caboza versus sunitinib, and we can see that 6.2% patients had progression in the combination arm, and 13.7% progression in the sunitinib arm. The median duration of response was also high in the combination arm, which was 23.1 versus 15.2 months in the sunitinib arm. So here if we subclassify according to the IMDC risk group, here also across all the subgroups favorable, intermediate and poor risk, we can see that the combination arm fared better as compared to the sunitinib alone. So moving on to the adverse effects and the toxicity profile, we can see that the common toxicities which we see in our clinics is like the diarrhea and hand and foot syndrome, which was also reflected in this trial, and we can see that the any grade toxicity was seen in 97%, and the diarrhea was a predominant side effect of the combination arm, which was seen in 55 of any grade, and grade 3 was seen in 7%. In comparison with sunitinib, it was 46, and any grade was 5. The other side effects are hand and foot syndrome, hypertension, and fatigue and hypothyroidism. But the grade 3 adverse effects which predominantly are our concerns are hypertension, diarrhea, and hand and foot syndrome. Definitely there is some the toxicity profile which we look are the mucositis, stomatitis, anemia, thrombocytopenia, and transaminitis, which was slightly higher in the combination arm, but the anemia was higher in the sunitinib arm. So if we talk about the treatment exposure and subsequent therapies, we can see that the median duration of treatment of Nivo plus Caboza was 21.8, and sunitinib it was 8.9%. The dose reduction was seen in 62.8% of patients in the combination arm versus 54% in the sunitinib alone. Treatment discontinuation was seen in 82 versus 90, and due to progression it was seen lesser in the combination arm versus sunitinib arm, and the subsequent therapy which was seen in was 36% in the combination arm Nivo plus Caboza, and it was 45% in the sunitinib arm. So we conclude that in the phase 3 checkmate 9-year trial, after a median follow-up of 3 years, the first line Nivo plus cabozantinib maintained superior overall survival over sunitinib in patients with advanced or metastatic RCC. The median OS with Nivo plus Caboza was 49.5 versus 35.5 months, which is nearly 14 months of OS advantage versus sunitinib, and the hazard ratio is 0.7, which is very impressive. The response rate also were higher in the combination arm versus sunitinib across all the IMDC subgroups. The use of subsequent therapies after discontinuation was also higher with sunitinib versus Nivolumab plus cabozantinib, and the results they continue to support the combination of Nivolumab along with cabozantinib as the first line treatment options for advanced or metastatic RCC. So the takeaway from my end is like the sustained OS is 3 years follow-up. The median duration of response was 22.1 months. There is a ORR data The time to subsequent therapy is also impressive, 20.6 months. There is a depth of response. There were a large number of patients who were poor risk patients. Nearly 19% of the patients in this trial were poor risk patients. The one variant which we are concerned is sarcomatous variant. In sarcomatous variant also, the PFS was 13.8 months and OS was 37.5 months. With this, I would like to end this. Thank you so much for attention.